Okay, so good afternoon, everybody. Today we have Heather Ellis with us. She is our dietitian extraordinaire on 6200, and she has agreed to give us some wonderful education to help us out with our patient assessment and getting them healthy and getting them home. So I'm going to let Heather take it away and go ahead and do her presentation.
Thanks, Melissa. Hi, everyone. So my name is Heather. I am one of the dietitians on CTU. I do specifically 6200, so 6med, CTU Blue, and I do the ER patients as well. So you'll see there is Sarah Katabarwa is one of the dietitians that used to work here and help me with this presentation. So she is on the front of that as well. So in this presentation, you'll find our outline is what is the role of a registered dietitian in the acute care setting? What is not dietary? Nutrition support, as well as MedPass. So the role of a clinical dietitian is not making soup, delivering meal trays, designing meal plans, researching the latest fad diet, or telling people what not to eat. So while we're completely capable of doing the following, in an acute care setting, our role just is a little different. The role of a clinical dietitian is identifying patients at nutrition risk, assessing, developing, and implementing nutrition care plans. Typically, we provide nutrition support either enterally or parenterally. We work with other team members to optimize care, and we educate family members and other members of the healthcare team. So patients at nutrition risk include patients with burns, wounds, head injuries, trauma, unintentional weight loss, dysphagia, or patients who are MPO for any duration of time. So we also review pertinent medical and surgical history, weight history, anthropometrics, food intake history, physical assessments when warranted, which is called an SGA. We also assess calorie, protein, fluid, and micronutrient needs for each patient. We assess and monitor the risk of refeeding syndrome, and we decide the best route and source for nutrition. We also look for patients who have unintentional weight loss and prolonged clear fluids, full fluids, or MPO duration. So it's okay to be MPO or clear fluids waiting for tests, but when it goes above and beyond about 3 days is when we start to get worried. And I will discuss what an SGA is, or a subjective global assessment, later on in the presentation. Next, we go into the prevalence and implications of malnutrition in acute care. So here we have malnutrition care for all. As part of our Canadian Malnutrition Awareness Week of 2022, we have a poster here. And so this just explains the prevalence of malnutrition in hospital, as well as what some of the things that occur in the hospital when it comes to weight loss, poor intake continuing in hospital when it was already happening outside in the community, as well as some factors that include cost of length of stay related to malnutrition. So considerations for intervention. So an SGA, a nutrition screen on the nursing admission. So patients who have answered both yes to the malnutrition screening questions on the nursing admission sheet. So have you been eating less? Have you lost weight? Those are important questions to us because that helps the nurses screen for us when the patient comes in. And then based on yeses from those two questions, it provides us the ability to get a consult and see those patients. Next, when to refer to the dietitian. So when patients who appear malnourished or emaciated, if they have said yes to unintentional weight loss on admission, patients who have pressure ulcers or wounds, as well as patients not eating or minimally eating. So NPO for greater than 3 days, clear fluids for greater than 3 days, full fluids for greater than 3 days, or if you or the care aides notice that there's minimal PO intake occurring. We also see patients with medical conditions, or we diagnose as seen below, so pre-existing tube feeds, or patients that require new tubes. So this could be a nasogastric tube, or the patient might be requiring during their admission a new percutaneous tube for long-term feeding as well. anyone with cystic fibrosis, COPD, IBD, so either Crohn's or ulcerative colitis, acute or chronic pancreatitis, liver cirrhosis or any type of liver disease, HIV, new colostomies or ileostomies, cancer, and newly diagnosed diabetes. When not to refer to the dietitian. So due to the high workload and the acuity of our patients that we have to see, the dietitians are unable to provide most education in hospital, and we rely on following in the community for chronic disease management. So we would refer to an outpatient dietitian. So these include heart healthy diets, pre-existing diabetes, obesity, and general healthy eating. And due to recent caseload demands since around 2020, we also have had a really hard time getting to new diagnoses of diabetes as well. So we heavily rely on our diabetes nurse educators in hospital, because they will go in and they'll discuss with the patient not only the insulin medications and the physiology and the pathology behind a diagnosis of diabetes, but they'll also discuss a bit of diet control, carbohydrates, protein, and identifying those foods. And then the dietitian in the community generally is able to prioritize these patients and see them quickly after discharge for follow-up education. So next we'll talk about optimizing PO intake. So we like to liberalize the diet. As you see there, we hate the diabetes diet, the heart healthy diets. Low sodium diets, we understand that they're necessary for short term, and for some patients, and depending on their disease state, is necessary in the long term, as well as fluid restrictions of 1 liter or less we try to avoid. They're very restrictive in hospital and really help to further along a patient's malnutrition. We also use supplements to optimize PO intake, and so this can include Boost, fruit juice, Ensure, Magic Cups. Those would be, and high protein, high calorie drinks would be what we call our oral nutrition supplements. We have MedPass, which is also an oral nutrition supplement. So that would be your Ensure Protein Max, 60 milliliters or more, 4 times a day. And the nurses would give that, and it's kept in an MedPass Ensure fridge on the unit. And then family bringing in food. We also do try and ask the patient's family to bring in food if they really are struggling. Some patients will even order in their own food occasionally. We just want them to eat, and whatever that looks like, we're happy with that. So this is what our MedPass order set sheet looks like. You might have seen it in the charts. If not, you might be seeing it sooner rather than later. So we basically start with trying to obtain a current weight. We know that that can be tricky on the unit, and not everyone can be weighed with the scales that we have on the unit currently. So we do our best to either use the weight that the patient or family report, estimate a weight ourselves, or try and get nursing to weigh. They do have a weigh every Monday, Thursday. We generally will pick one day or another, or we'll change the date. And then we do have to go down to the different options. So we have the option, which is the standard 60 milliliters 4 times a day. We can make it 90, we can make it 120 based on the Ensure cups that are on the unit as well, with the individual measurements on there already. So we try to make it as easy as possible. And it is good to note that the MedPass sheet says at the top that it is okay to use for patients who are on thick and full fluids or thick and liquid diets. We generally do call the speech language pathologist just to make sure they're okay with us using it, but it is technically safe to be used for thick and fluid diets. It's also, I believe, halal, and it's low lactose, and I believe it's kosher as well. The only patients that wouldn't really do well with MedPass would be patients that don't like vanilla Ensure. That unfortunately the speech language pathologist is worried about the texture and want the liquids very, very thick. So then MedPass wouldn't be safe for that patient based on the SLP, or for patients who have a true milk allergy. And so this isn't a patient who is lactose intolerant, who doesn't drink milk but eats cheese. This would be a patient with a true allergic reaction to any type of dairy protein. Next, we'll get into the nutrition support services. So sometimes there is some confusion on the unit about what this means. You might see in charts, we write our suggestions or we write our progress notes as the NSS dietitian. This is just a way for us to designate that the patient is either getting parenteral nutrition, getting a long-term tube, getting an NJ. So who is the nutrition support services? That would be two general surgeons that we work with. We have Dr. Canthan and Dr. Stevenson, and then the registered dietitian who is either already following that patient or is the dietitian on that team. This ensures high quality, evidence-based and consistent nutrition care and follow-up for patients requiring TPN, PPN, insertion of an NJ, or a long-term feeding tube, such as a PG, a PEG, or a PGJ. All long-term feeding tube insertions at RUH require a nutrition support consult to ensure long-term follow-up. Sometimes you might see that the physician will write an IR insertion of a tube without a nutrition support consult in the chart. Radiology will actually ask for the nutrition support consult before they place any tubes. So if you see that that has happened, feel free to send a consult to the dietitian through SCM, the normal way that you would for any nutrition consults, and just write NSS consult, please, and we'll be able to prioritize that. Next, we talk about the different tubes that we have. So these are our short-term tubes. So we have our OG or our NG Salem sump. So you can use for suction or for feeds. The OG you wouldn't see on the unit. You would see that in the ICU. Once they're extubated in the ICU, generally they're switched to a small bore feeding tube, which would be your small bore NG, but not always. So the NG Salem sump, you can still use it for feeding. It's just usually bigger. It's usually more rigid, so a little bit less comfortable for the patient. Whereas the small bore tube is a 10 to a 12 French, much more comfortable, much more flexible. And then we also have the option of our NJs. So those are for specific patients who have either trialed an NG feed and it didn't go well, or have something like gastroparesis where their stomach isn't emptying properly, and so we need to feed a little bit lower into the jejunum instead of the stomach. And here we have our long-term tubes. So for our PEGs, those are placed in medical daycare with the use of an endoscope. And we generally rotate those once a week right from the get-go. That helps with the healing process and helps to avoid buried bumper syndrome. So when the PEG is inserted, it has a plastic little mushroom that pulls the stomach up to the abdominal wall. And so by rotating that, you're making sure that it doesn't adhere to the stomach wall and eventually start to push its way through. And that would ruin the integrity of the site and cause issues. So the tube doesn't have any sutures. It's just placed and you're good to go. So either one of our doctors generally place those. Either Dr. Stevenson or Dr. Canthan would place those. The PGs, so those are the percutaneous gastrostomy tubes. They are placed in radiology. They're generally a 14 French tube, and they do require a Salem to be inserted the night before. So generally, if our patients have a small bore NG in place, we would ask that a large bore NG be placed in order to receive the polybar that goes in for imaging, and then to help with suctioning post-insertion of the PG. And there are pre-PG order sets that do get sent up to the unit from radiology that do specify this as well. So these types of tubes are not placed with the mushroom in the inside. They're actually placed with a balloon full of generally normal saline that holds the stomach into the abdominal wall, very similar to the PEG, but just with a balloon. So generally there's anywhere between 5 to 10 milliliters of water or normal saline in that balloon. And those you do have to rotate weekly. However, they do come up from radiology with sutures in place to help keep the stomach adhered to the abdominal wall until the feeding tube tract has fully healed. It takes about 6 to 8 weeks. So Generally on the post-PG order sets that come up from radiology, you would have instructions from the radiologist that placed the PG telling you whether or not you have to cut the sutures in 5 days, 7 days, 21 days, depending on the radiologist. The suture time in the abdomen will change. And then we do have the PGJs. So that is generally a PG that goes through the stomach and then down, threaded into the jejunum. We generally don't see a lot of these on the unit. They're for very specific patients who have issues with, again, their stomach not functioning properly. So something like gastroparesis, or for patients that, have chronic pancreatitis and we can't get them tolerating a gastric feed and they require a jejunal tube. These do not get rotated. Any small intestine tube does not get rotated. And then there is the surgical jejunostomy, which we also don't see very often, especially on CTU. And that would be, again, a tube that you would not rotate.
Heather, I'm just going to interrupt you. If you wouldn't mind going back to the last slide. We do see, we see a few of them here and there, and I just feel that we are not experts in tubes. Maybe one thing we could just quickly touch on is things to quickly look for when you're looking at the tube to identify what it is.
Absolutely.
I think that's something that the staff would probably find really beneficial, because I know I still even have issues sometimes between the difference between a PEG and a PG. PGJ is pretty much given, and then just, again, remember not to rotate those guys. But yeah, I think just that they know how to identify, if you just will have some tips for us.
Yeah, absolutely. So the biggest tip is a PEG has 2 ports. You have your med port, you have your feed port. Your PG will have 3 ports. You'll have a med port, a feed port, and a balloon port, and they'll all be labeled as well. So if you see 3 ports and one of them says balloon, more than likely you have a PG. A PEG will never have 3 ports on it, and a PEG will never need a balloon. And sometimes the shaft as well of the PG will say 14 French end to it, and that's another device to use to determine whether it's a PG or a PEG, because our PEGs are not an end to it tube. That is specific to the PGs that we place. So if you have 3 ports, it says 14 French end to it, more than likely you have a PG. And if you have 2 ports, generally they're red ports, and you have a 20 French tube, it might say 20 French on the shaft, it might not. That would be your indicator that you have a PEG in situ. So next we'll move on to parenteral nutrition. So TPN versus PPN. So generally for our PN orders, the orders are due to pharmacy for 1100 hours. So that means in the morning we get our blood work, we have to write our orders, and we have to get them signed and down to pharmacy before 1100 hours. We generally try and get our blood work for 0600 hours, so it gives time for either nurses or phlebotomy to get the blood, send the blood down to the lab, and hopefully get the blood back up with the results before we have to order the PN. There are 2 different types of PN bags as well. There's the commercially available and there's the compounded PN. So the compounded PN is probably the one that you'll see the most on the unit, and that's the 1 bag. It's milky colored looking, and that's the one that runs for 24 hours a day. It has the set electrolytes that we've added. There's a few different solutions for us to choose from. And that is the one that pharmacy compounds here in hospital. So we have to have the orders in by 11 because they compound for all hospitals in the city. The commercially available is available for us to use after 1100 hours when we no longer have the opportunity to compound a special bag for the patient. It's a set bag with set electrolytes. We have 2 options, either 1 solution for a central infusion or 1 solution for a peripheral infusion. And then it has set electrolyte provisions as well. And that would be the one, they break it open and roll it, and it mixes everything together. One of the biggest questions I get from nurses about the commercially available bag is that perhaps there might be more than 1 bag in the fridge. So if you get a PN bag and the order is for it to run, let's say it's going to run 50 mils an hour to give you a 1200 mils for a 24-hour period, and you run out of your bag a few hours early, that would be a sign that it's a commercially available bag, and there's probably another bag somewhere either in the one of the med fridges on the unit that would have another bag for that patient. And maybe that second bag, you won't use it all. That's okay. They only come in 2 sizes. They come in a 500 and they come in 1,000. And so usually they send up the 1,000 ml bags. So there is some wastage, and that's okay. And then the other question we get a lot is central versus peripheral. So our best option is always the PICC line if somebody needs a long-term amount of parenteral nutrition. So if somebody has high needs, they're going to be on it for longer than about 2 weeks, then we would want a PICC line for central access because it gives us more options and availability to adjust electrolyte provisions. Also helps us to provide more protein, calories, and lipid through the PICC line. We do have the option though, if the patient only needs PN for, let's say, a few days to a week, and they have pretty good vein access, peripherally, we can run peripheral solution through just like a regular peripheral IV. Generally, we can run from an 18 to a 22 gauge. Generally, we like to have an 18, but we understand that not everyone's veins accept an 18 gauge IV, so we can do up to 22 gauge as needed. And generally it works in a straighter vein, but again, if we have to work with what we've got, sometimes it works, sometimes it doesn't, and we can always troubleshoot afterwards if something doesn't work. So I kind of went into this a little bit, but length of time for the PN required would help us make a decision as to whether TPN or PPN would be required, as well as if the patient has good vein access or not. That would be an indication that we would be able to do peripheral or not. We do have the type of access again. So a PICC line is generally what we use for central access for TPN. PPN would be your peripheral access, 18 to 22 gauge in a straight vein. So when a patient might need PN, some of the indications would be being unable to meet their needs enterally, having a bowel obstruction, having an high output fistula, having intestinal failure, mesenteric ischemia, severe mucositis or nephritis, extensive GI surgeries with unstable anastomosis, an ileus or acute necrotizing pancreatitis. And contraindications to having parenteral nutrition would be a functioning GI tract. We always like to say if the gut works, feed it. And so we would try and do enteral if the gut is functional, and TPN or PPN doesn't seem to be the best option at that time. The inability to gain vein access would be another reason. That would be a contraindication. Risks exceed the benefits, or treatment is anticipated to be less than 5 days in a well-nourished patient. We also have to consider comorbidities such as heart failure for patients receiving parenteral nutrition. It is a lot of volume going in, especially with peripheral PN. The limit that we have is about 3 liters, but still for some patients that might be too much. However, if we go too low on the amount of fluid, then they're not getting very much nutrition either. So it is a bit of a balancing act when there is some comorbidities involved. We look at the volume status of the patient as well. How edematous are they? What is their kidney function looking like? And again, going back to the calorie and protein requirements, we do try our best to work within the solutions that we have available. We have 3 central solutions. We have a high protein, a medium protein, and a low protein solution. And then we have our 1 peripheral solution of our compounded bags. So we do our best to fit the patient into the solutions that we have. And again, it also is based on the amount of volume of liquid the patient is going to be able to tolerate as well. And then we do adjust electrolyte requirements as needed. Generally, for the first 7 days, we do electrolyte requirements every single day. So you might see us asking for blood work every day, coming around the chart every day, writing a new order every day. And that's just because we need to monitor for refeeding syndrome and make sure that the patient's getting the appropriate electrolyte provisions in the TPN bag. And so we will make little tweaks here and there as needed. And we might ask for some corrections depending on whether the amount of generally it's phosphate is maxed out in the bag or magnesium is maxed out in the bag for the rate allowable. And that's determined by pharmacy and their compounding machines. So we don't get any precipitate in the bag. And this is one of our parenteral nutrition order forms. This would be the one compounded through pharmacy. So this would be needed before 1100 hours. You can see that we do have the 4 separate bases there as solutions. On the left, we have the electrolyte provisions on the right, and then we have a few other things that we can change. So if the chloride in the patient is getting quite high, we can minimize the chloride in the bag just to help bring that chloride down. If the patient is requiring any additional trace elements or has any issues with liver failure or kidney failure, we can adjust the electrolyte or we can adjust the micronutrients in the bag to try and minimize damage to the liver and to the kidneys. And you'll see at the bottom, it has either the option of a continuous infusion or it has the option of a cyclical infusion. And then we have underneath that when to reorder. So it'll be either we reorder every single day, we reorder every couple of days, depending on how we're feeling, or if the person is stable, we can reorder every Thursday. And this is our 2-in-1. So we don't use this often on the unit. This would be if somebody has some sort of allergy to our standard lipid that we use in the bags that you saw previously. This we would be able to actually give them a solution that is amino acids, dextrose, and then apply a lipid separately so that we can make sure that they're not allergic to the lipid that we're giving them. This would also be important if the patient is having, let's say, high triglycerides. And so we might need to make sure that we're minimizing, again, damage to the liver the best that we can. And we might need to give them a few breaks off of lipid or give them lipid separately for a couple of days, give them no lipid for a couple of days. And this would be the standard commercially available bag. So this would be the one that you'd see if we're starting it after 1100 hours. So this is the 2 solutions, one peripherally, one central. It's only good for 1 day. So we would have to come back the next day and write a different order set from one of the previous order sets that you'd seen. And so that's everything that we had in our presentation. But feel free, we are always around the unit or we're easily reachable by our phones. Oh. I was going to say by our pagers as well, not our phones. So always feel free. If you see us on the unit, just ask us any questions. We're more than happy to answer questions. If it's not me, it'll be one of my coworkers. So absolutely, we're here to help. We're here to answer questions, and we also help with issues with the kitchen too. So we will help liaise with the kitchen as needed. We'll help advocate for patients and their diets if they're not great. We just want to see our patients nourished.
Awesome. I just want to ask a quick question, Heather. So yeah. A lot of our population, you know, they come in, our patients with addictions or the extenuating social issues that aren't getting adequate nutrition outside of the hospital. I mean, I think a lot of our clientele is, but we do see it prominently in those patients or sometimes in our elderly that are living alone. I guess the one question I have is that, so when they do come in, if their albumin is low and their pre-albumin is low, can you tell roughly just by that, like how long have they been malnourished? Is there any kind of correlation that you use with that?
Not necessarily. So albumin is generally a not well used marker for nutrition. So we don't really look at it or use it anymore specifically on our unit. Pre-albumin would be more for, it'd be a little bit more sensitive to malnutrition. But again, generally when people are in hospital, their CRPs are high or they're inflamed or there's reasons why their pre-albumin might be low. So we use it with a grain of salt. Generally, we would ask the patient and talk to the patient and just kind of try and gather a picture of how long has this been going on for? Have you been eating normal amounts? Basically, word of mouth from patient and from family would have more of an give us more of an idea of how long they've been malnourished, more than albumin or pre-albumin.
Perfect. Okay, another question I had. This is like just one of those, another question. So if you have a patient that's on parenteral nutrition, whether it's TPN or PPN, does that help increase your oncotic pressure? So if you have someone that's sort of spacing quite a bit, or you have someone who's kind of on that septic threshold, does having that help increase pressure? I don't know. It's just like one of those.
You know, that's a good question. It is an IV fluid.
Yeah. And so it would have probably a high molecular.
Yeah, it would, because it does have calories from the dextrose. It does have the lipid. It does have the amino acid in there. So there, maybe.
One of those things.
That's a great question. I'm going to talk to my coworkers about that, try and find an answer for you.
Yeah, what was another thing I was going to ask? Oh, in our patients too that have, if there's a reason that they can't eat, and there are patients that have liver failure, what is the typical thing that we would see in them, because they already have that liver profile, right? So would we be utilizing PPN or TPN in those patients, or would we be looking at an alternative source of nutrition if they can't maintain basic?
You know, that's a great question as well, because we do have a lot of liver patients on the unit.
Yeah.
We kind of try and triage them to figure out what is the game plan. If they're a transplant patient, generally we try to be more aggressive with nutrition.
Okay.
And we would try and avoid TPN or PN in any fashion, because the liver is how we process our parenteral nutrition. It's already damaged. We don't want to add extra stress to it unless we absolutely have to. We have no other option. So the best would be enteral nutrition to try and supplement oral intake. However, we can try and optimize oral nutrition as able. Generally with patients with liver failure and ascites, we try and say small frequent meals, lots of high protein, very concentrated options throughout the day as well. And even overnight, because they don't have the glycogen stores that we do. So then they don't have that ability to go long periods of time, especially overnight, with the small little dribbles of glycogen throughout the night. So I usually will try and give a big HS snack and say, eat it throughout the night if you wake up.
Yeah.
It's very small frequent for them.
Yeah. What other questions do I have? Oh, we talked about wounds. I just wanted to reiterate again how important it is, and it's been wound therapy and our dietitians are such a collaborative practice, and just always make sure that if you have a patient that you notice has starting to have breakdown, that the dietitian has been consulted. It's really important that we maintain and get on top of the nutrition right away, so that we don't have further, well, your wounds aren't going to heal if you don't have proper nutrition. So I just want everybody to remember that as well, because we have seen, we do get wounds and we just want to make sure. But I always say, have you consulted the dietitian? Has Heather know about this patient?
And usually wound care and occupational therapy will also ask me about that too, if nursing hasn't noticed or they're breaking down, or it's just like new and the nurses are busy that day. Wound care or occupational therapy will generally find me too and be like, have you seen this patient?
Good.
So it's definitely collaborative.
Good. That's exactly what we need. We need everybody to be working together. No, that's really good. I think that with their questions, we all know how to find you.
Absolutely.
And I really appreciate you taking the time out of your day to do this presentation for us. And again, it's just always nice to have that clarification. And the discussion with tubes is great. Oh, one more thing I wanted to just point out or advocate for is on the weekend. When we get, or if we get patients that are admitted for some reason they're MPO or they don't have adequate nutrition, I just want you to just, how can our nurses advocate to the physicians, like they need to have something, whether it's Promote or something, with Salem, something just for the weekend to get us through. I think that's the big thing, is a lot of times what happens is our residents won't come and put a small bore in. So we just need to be a little more, just advocate again for more initial investment or involvement in feeding them.
Absolutely. And small bore is our golden option, but if it's not an option, food is an option. So really, if it comes between a patient getting nothing for a weekend or getting a Salem sump with something, a Salem sump with something is better than nothing. And there is an on-call dietitian every stat holiday, every weekend from 8 to 4:30, so they can always be called as well for assistance.
Perfect. That's great. Just because I know that in the past we have, there's always those patients that kind of roll in and they don't get fed or something happens, and we do get the occasional orthopedic patient. So, and we've had this conversation previously. So those patients end up being NPO all day until late at night, and then they've gone 3 days without proper feed. So just something that I want everybody to be aware of is that the nutrition component, so it impacts their stay, it impacts their progression, their healing. We know that. Sometimes it's just, we have to vocalize it to the doctors. I don't know.
Yeah. Oh, and I guess before I conclude, I will mention one thing that I forgot to put in this presentation. It's been happening a little bit more frequently now because we've been having a lot more long-term tubes on the unit in the last year or so. So definitely if the patient has a long-term tube and it falls out, it gets pulled out, it's so important to make sure that a Foley goes into the site. It's not to be used for feeding. It's just as a placeholder because those sites hold up or close up so quickly that even if we leave it for 8 hours, the likelihood of us getting another tube in that same spot is so slim.
Yeah, that's a very good point, and it is in the policy. I think that sometimes there's confusion between, like you said, you're not to be giving anything through it. A lot of times that it's just there for a placeholder, and if we can get them to have a replacement tube, or we can find someone who's certified to quickly pop a new one in if we need.
Absolutely.
But yes, definitely put a Foley in, inflate the balloon. It's there literally for placeholders, so we can keep that tract open.
Yeah.
Very good point. Very good point. Awesome. Okay.
Awesome.
Thanks so much. Thanks again.
Thanks so much for the opportunity.
Absolutely, anytime. All right, we'll talk to you later. Thanks, Heather.
Sounds good. Bye.
Bye.